You're listening to Aging Uncensored.
Welcome to Aging Uncensored, where we unpack all of the things aging, improving our lives, what it means to take care of our loved ones and our friends that may have a chronic illness, changes, what it means to basically get older, right? And there are some great things about getting older. There are some things that can be challenging. And we're just so glad to be back. It's been a few weeks since we've had our podcast, and I love that I'm introducing my friend again, Marianthe Grammas, Dr. Marianthe Grammas, who is the medical director for UAB House Calls. And as you know, she is a very experienced and well-known geriatrician here in Birmingham and in the Southeast. She's helped me with lots of clients, but personally, I think I shared last time, she's helped me with several of my family members. So I've been in the trenches with you, Marianthe.
Yes, we have.
So I'm so glad to have you back again. And we always just have a good time talking, unpacking all the things.
That's right.
A lot of it is just stories from the gridiron, I guess you would say.
Things that you would never think you would see or hear or do or experience, and then they become kind of normal, and then you're like, I think I've seen it all, and then you see something else. And you're like, all right, well,
curveballs thrown
bring
at
it.
you.
Yeah. Let's figure this out together.
That's right. That's right. Okay, so you just said that. We're going to figure this thing out together. One of the things that I say a lot in healthcare, specifically geriatric care, senior care, let's just call it managing chronic care,
Right.
is families don't understand how siloed the healthcare system is, right? They really think that our primary care physician is automatically saying, good primary care physicians are going to do this, but primary care physician is going to automatically speak to the specialists. They're all going to have relationships with home health and the pharmacies. They're going to think about different disciplines. Is that the norm?
No, it's not the norm. And I believe that this did not happen intentionally. I think that everybody, as healthcare has grown and we've gone from being, simply primary care physicians, surgeons, and some specialties to now a very, multi-pronged healthcare system with all kinds of providers and ancillary staff and interprofessionals that, without really realizing it, everybody is kind of working in their lane and charged with their specific evaluation of someone. And if there's not a built-in mechanism for people to communicate with each other, you're sort of just hoping that people are doing that. And like you said, patients and family members, they don't know what's happening behind the scenes, and they probably assume that that's happening, that people are communicating with each other. That's why I think what you all do in care management and at Life Care Solutions is it's brilliant, because you are like a glue for family members. You guys are like a glue with being connectors and bringing all those pieces together for people who really need help with that care navigation. But no, it's not the norm for people to be communicating with each other and in a way that really helps to push the care of a patient forward. Again, not because we don't want to and we're not well-meaning, but we're all busy doing our other things. And so you depend on people reading charts or reading messages or things like that, and with all the advances in technology, it's gotten so easy to just put it down in a text or put it down in a note and expect that somehow it's going to all come together.
Right. Sure. And most patients aren't going to have a care manager.
Right.
And most patients aren't going to have a physician coming into the home with a team coming into the home that also has a whole nother team within the background.
Right.
Right. So we're going to introduce a term.
Yeah.
Interdisciplinary care team.
Right.
And I will say, when I spoke to the Auburn College of Nursing and their professors, and we were going over the guide model and going over the our model of how we deliver care. They got so excited. It was almost like they were salivating when we were talking about interdisciplinary care teams, because we're fortunate enough that within our care management practice, we have folks with different disciplines, nursing, gerontology, psych, counseling, PT, OT. That is what y'all developed.
Right.
So talk about what the model looks like, what y'all are doing, and how interdisciplinary care team what's kind of the primary focus for that? And then kind of go into the...
Yeah. So I think taking a step back for people to realize that having interdisciplinary care, meaning you have provider, you have specialists, you may have therapists, you may have a nutritionist, you may have a case manager, does not mean that you have an interdisciplinary care team.
Great point.
Yeah, because in order to call yourself a team, really, you need to all be working towards the same goal.
Right.
And so for like a sports team, that's to play your very best, to support each other, to be, calling each other out, when you need to do something differently or anticipating the next play, but ultimately to like win the game.
Sure.
Right. And to be the best at whatever the thing is that you're trying to do in a team. Well, in a healthcare team or an interdisciplinary team, you need to have that same kind of mission and vision, which is that you are all working together, playing your different position, whatever it is, and probably led by a coach of some sort or some facilitator who kind of keeps everybody on track for the betterment of the patient's care. So, everybody's got their role, their position, their area of expertise, but they still need to be communicating with each other,
right,
in order for it to be an effective team. And I think that that's where sometimes people think, oh, but you've got all these people taking care of you, but that's not the same thing as having them all communicating.
Sure.
So I think like what we do at UAB House Calls, and I'm sure, you guys probably do this at Life Care, and other really high functioning teams, is that we build in a platform for communication. One way of doing that is through a weekly interdisciplinary team meeting where we gather together around a table, or have people on Zoom if they can't be present. But that's where we spend time talking about the cases that we need to discuss as a group, where we celebrate each other, highlight somebody's area of expertise and something that went really well. And then when we dive into a case that needs the expertise and the knowledge and then the strategic thinking of the group to help move a patient's care plan forward. In the world we practice in today, people are in all sorts of spaces, and sometimes it's hard to physically come together as a group. I will tell you, though, I still think that's the most effective way to have an interdisciplinary team care meeting. Now, if that's not doable on a regular basis, then people can have, you can have HIPAA secure team threads where you can communicate, if you need to, with your social worker or your case manager, or, in our messaging center at UAB, I work hard as a PCP to try to bring together some of those other disciplines that may be taking care of patients so that we're at least all in the same message at the same time.
Right.
Sure. So those are some things, but I think you have to have that. We're all working towards the betterment of the patient, and we are humble. We have to be humble and be ready to hear what other people have to say. There's a whole lot more to say about that and why that's important. And then you have to be able to have some way of really communicating effectively with each other.
Sure. I'm so glad that you brought that up, because again, patients may have these different, I go see physical therapy here, I may have this doctor here, I may have that, but that's the silo.
Right.
That doesn't mean they're all on the same team.
Right.
Right. And so we didn't even talk about this, but let's just kind of go the difference in hospital settings. When somebody's an inpatient and you've got a hospital or a healthcare system that takes into effect kind of a team approach like that, where you're bringing different therapies versus something else. And what should we tell people to ask for to kind of bring that together, at least just in the inpatient setting? Because that may be a place, like if you don't have access to UAB or something like that, that may be the first place where you might could get somebody all on board.
Yeah. Well, I think, each hospital system likely has its own process for this, but I know like in our health system at UAB, all of the inpatient units have TOC rounds every single day. So transition of care rounds. And that is where they bring together the interdisciplinary team members for that specific unit, whether it's, the trauma unit or a hospitalist unit or the geri psych unit or whatever it is. But you'll typically see, sitting around the table for like an hour, you'll see the clinical providers, you'll see the social workers, the nurses for those patients, sometimes pharmacy, nutrition, PT, OT, and depending on what unit it is, you may have other disciplines represented. I mean, the trauma unit is a great example of bringing together surgeons and medical providers and different therapists and counseling and all those, but they do get together every day at typically the same time every day to talk about the new patients, the patients who are planning to transition home, and they have those opportunities to to talk to each other. I think one thing that we try to do, because my team doesn't take care of patients in the hospital. Right. However, we don't want all of the knowledge that we have about our patients from all the different angles to go lost when a patient's in the hospital. So we will reach out to whoever it is, whether it's the hospitalist or the inpatient case manager or social worker, to say, hey, let us provide you with some of this important contextual information. Right. And that will help kind of bring some continuity to that inpatient care team. And then I usually will encourage patients or family members, because a lot of times, and this is a great example of where that fragmentation plays out, they're in the hospital, right? They got somebody coming in to see them every single day, multiple times a day. And yet they reach out to us as their primary care and say, we don't know what's going on with mom. Can you give us a call? Right. And I'm like, oh, that's so sad that you've got people coming in and out all day long, but you are so confused. Yeah. And that's a great example of where there's not a clear communication, or there's been a communication breakdown. So I just tell, folks to not be afraid to advocate for themselves. That's right. And say, can you, we're getting a message from one provider set that says this, and then this other team is telling us this. Can y'all get in a room together and talk? Or, we're feeling like there's
kind of form your own transitional, what do you call it? Transitional care.
Transitions of care rounds.
Transitions of care rounds. TSC. Yeah. I'm going to remember that
that's
now.
Right. That's
You're
right.
kind of building your own.
Yeah.
And then when they look at you like, what does that mean?
Yeah.
If they start questioning you, then you need to probably advocate more.
That's right. And I think that I'm on this professionalism advisory committee at UAB, which it's really been cool because it's bringing together people from across the organization, also different disciplines, to talk about core values and how they ought to be played out in with what types of behaviors, like what represents owning it, what represents doing right, what represents always caring, what represents working together. So the last one we had was work together, and we talked a lot about collaboration. And what a couple of the things that really came up were that the patient has to remain at the center of our world. Really. I mean, we need to be supporting each other and taking care of our teams, and that is very important. However, if we forget that, at the end of the day, the person we're working for is, that patient, then really doing the right thing should be very apparent. Right. And we also talked about the importance of needing to have more intentional time when disciplines can actually come together and sit around a table and talk about patients, because so much happens, like I said earlier, through chart reading, yep. Or chart messaging. And I mean, that's just
generic to me.
Yeah. And there's only so much you can say in a chart, right? Because you're not going to put all of the deep contextual information into a message, right? You're just going to say the thing that you think needs to happen. But there's a lot of context there, right, that people need to know. And it's whenever I've reached out to provide that, or had a social worker reach out to provide that, the receiving team is always so appreciative. Yeah. So I think interdisciplinary care teams are all about highly functioning interprofessionals, top of their scope from their own unique perspectives, coming together communicating well, and improving the outcomes of patients. To be in a team like that, you have to be humble.
That's right.
You have to sit back and say, my perspective is not the only perspective in the room.
Right.
I can't make a good clinical decision if I don't hear about what their physical functioning is from the PT.
Right.
Or, I could have this great medical care plan, but if they're going home to absolutely zero social support,
That's right.
then how is that going to even play out, right?
And then even understanding the person, the patient, the patient's family, the folks that are going to be the ones following that discharge plan, understand what their beliefs are, understand kind of their ability to even understand healthcare, right? So there's such a great health illiteracy breakdown in Alabama and in a lot of areas. But when I think about that, when you think about being humble and you go back to the center of the person, it's the kind of terms that we use a lot: holistic care, whole person care, person-centered care. Right. It always amazed me when we have all this training on person-centered care, and it sounds like such a new, novel idea, but all it means is that you actually take the time to talk to the patient, talk to the centers of influence of the patient, like the social support and things like that, and understand what their goals of care are. Because what I may be putting on you as what I think should be your goal of care may not be what you're wanting to do.
Right. And that goes back to something we talked about in the other podcast that we did, was that what matters most.
Yep.
The question of, and if what matters most to the patient and the family, as much as possible drives the care plan, it's a lot more likely to be successful and well received than if you're driving a care plan that matters most to the MD, right? Or that matters most to any other member of the team, right? If it's ignoring what the goals of the patient are, what's feasible within their living situation, within their socioeconomic, area, their functional capacity, then we're setting them up to not be successful.
Right.
And I think that the humility there too is to say, we meet people where they are.
That's right.
And we cannot fix every problem there is. And sometimes trying to fix things actually makes them worse.
Oh my
Actually
goodness,
breaks
yes.
things, right? And so sometimes it's the social worker or the therapist that you need to be listening to the most, who got, you wonder why the person's always in the hospital. Well, they keep falling because there's, trip hazard everywhere, or they can't take their medicines because they have dementia and their eyesight's poor and they don't have a caregiver there. And so why are you going to keep prescribing them more?
Right.
So if you don't step back and listen to the other members of your team and fine tune the care plan based on what you're hearing and learning, then you'll be frustrated and you'll burn out more, because ultimately we want our patients to do well. Right? Most people want their patients to do well, but we have to step back and say that doing well may look differently.
Right. Yeah. How do you define
doing well? And doing well may be by what they define as doing well.
Right.
So I think that's also, you have to be humble, and you have to be willing to listen, and to listen to understand what people are saying, and not just to respond and give your own your own input.
Right. Absolutely. So, obviously you guys have a unique situation. You're able to bring in a lot of disciplines. From just, a family out there, and they're trying to understand what that looks like. Who would be, how would they get started? And how would they even ask those questions, maybe, of their primary care provider,
I think a lot of people come to the doctor's office and they are just waiting to hear what the doctor has to tell them.
Yeah.
And, they may come with questions if they feel empowered, but they may just be sitting there and they have all these thoughts, but they get to the office and they're so anxious because that's
white coat,
right? I think that it's important for especially the population that you and I take care of a lot, the older adult population, to really instill in them early that at some point it's going to be important for them to have someone in their visits with them.
Yep.
A care partner, you know, somebody they trust.
Let's repeat and emphasize that.
Yeah.
Because how many times
That's right.
have you seen when you were in the geriatrics clinic, the patient coming in, and then they're either not giving you a lot of information, they're not taking notes, probably because they don't understand. And then you're probably getting a patient portal message, if the family was able to get on the portal, that, hey, doc, I really would like to be there with mom, but mom doesn't want. So let's emphasize that.
Yeah.
At some point in time, you need to have a second set of ears with you.
Yeah. And I think that that's, you know, what is the marker of time? It's hard to say because every patient's different. So we talked earlier about like the age thing, right?
Yeah.
There's no like magic age here. But I think as you're starting as whether it's, you know, a provider or a nurse, case manager, anybody can feel empowered to share this with their patients or their patient's spouse or children. But to say that like, hey, you know, I need you to think about things are just getting a little complicated. And I use my own self as an example whenever it comes to talking about like medications that, you know, once I got more than 3 medicines, I got a pill box because I couldn't keep up with doing it right. So
100%.
it is not a flaw. It's not a weakness. It's actually a strength to adapt to changes, right? To not fail because you're not adapting. And one adaptation of medical care, you know, getting more complicated is to have somebody with you, an advocate, a care partner, another set of ears, so that you can focus on talking about what's going on, and that person can be there to take your notes, or, you know, maybe y'all talked a little bit ahead of the visit when you weren't nervous, and then if you forget something that you need to say, that person is there to say, oh, by the way, you know, let's not forget about that, and then to help, you know, kind of navigate going forward.
That's right. And then, you know, if somebody if that person can't physically be available, then encourage writing down some questions to take in, and then have them on FaceTime or have them on, you know, on the telephone.
Yeah.
So, I mean, that is completely appropriate.
Right. Absolutely. And, you know, everybody wants their visits to be, whatever discipline it is, to be like high yield visits. And so the more information that you can bring to the table at the outset, and then have that time with your provider, the better. Because if it's like, oh, by the way, I forgot, you know, and then it's a day later, 3 days later, 5 days later, I mean, that increases kind of the fragmentation, because then maybe it's some other person who's getting the information on the portal or, you know, a phone call. But yeah, I think it's helping people to understand that having somebody there with you is important.
That's part of being on your interdisciplinary care team.
Yeah.
It doesn't have to be somebody that has a license.
Yeah.
It can be your advocate, your social support. And don't be afraid, particularly when you've got, you know, let's say you're in neurology or oncology and you've got medications coming at you that, I mean, I remember sitting with a family member and we were in a neurology office, and the neurologist was incredible and he was describing so many things. And if he was going too fast, I just said, hold on, you know, walk me through that again.
Yeah.
And then when he came up with a medicine, I was like, can you just spell that for me?
Yeah.
You know, and that's okay to do those things.
Yeah. I think the other thing that patients ought to feel empowered to do, and they may think, oh, I don't have a right to ask my doctor to do this or whatever, but I think it's fine for a patient to say, you know, I've had people tell me this a lot, or family members to say, like, do we still need to see all these other doctors? Can you look at all of our medicines? Do they still make sense? I think, again, like, patients often will just take for granted that this is like the treadmill that they're on, and they just have to keep running on this treadmill because that's what they think they have to do. But in fact, you know, treadmills can change speed. You can slow it down. You can speed it up. You know what I mean? You can step off of it for a little bit and get back on it. So I think, like, patients should be empowered to say, can we just pause a second, and I just need somebody to really be like the quarterback of my healthcare, because you're my primary, or maybe it's the case manager. I just feel like I have so many people and I don't know, I get different information from people, and could you just help me get everybody on the same page?
Right.
And I think that like the person who hears that, if they understand the intent and they can hear the, maybe the frustration or the confusion of their patient and caregivers, then they'll, I can't imagine anybody not wanting to help.
Right.
And it may be like a, that's, I'll lean on my case managers, my social workers, but we also can just get caught up. The providers can also get caught up in the treadmill. Right. And so they sometimes need to be encouraged to slow down.
Sure.
And take a step back and look at the whole picture.
I mean, there could be a physical therapist or occupational therapist that's going in from home health and sees something, right, and then they go, hey, you need to call your primary about this.
That is right.
And I would hope any primary care physician or the physician that ordered that home health would want to take that information and do the right thing.
Yeah. And for the people who are listening, I mean, I know there are different roles and stuff. I think it's also helpful to, again, it's about that direct communication. But if you know that your client or your patient or your loved one is being, followed by somebody, but you've never had the opportunity to talk to them yourselves, then maybe just, I've done this before. I've called a home health agency and I've said, I'm hearing this from my patient, but it doesn't match what I see. And let me just call their physical therapist with home health agency X and see what they're seeing,
Right.
like, so because, and I think that that's a very good way to, to bridge, and gathering more knowledge from the other members of the care team.
Absolutely. So, you can be in a situation where you're part of a practice or a system that automatically has that built in. But what we're saying today is you can build your own, by being an advocate and recognizing that you kind of have, you probably will be building it on your own unless you've got some support like we provide. But it's okay to advocate. Matter of fact, it's more than okay to advocate. It's okay to ask questions and do all those things.
I tell a lot of the residents who come through like geriatrics or house calls that I understand that this is not necessarily a task that every provider can have. But if you're a geriatrician, if you're a case manager, if you're a PCP, then my expectation is that you know more about your patients than anybody else taking care of them does, because somebody has to own their care. Yep. And so you don't have to know all the weeds and the details, but you need to know who all the players are.
Right.
And you need to know who to talk to about whatever issue. Because let me also tell you that when those patients get that survey after their visits, one of the very first questions is, do you feel that your provider knows your medical history?
Ooh.
So like if you walk into the room and you're like, hey, how you doing? So good to see you. And they're like, well, did you know that I had surgery a month ago? And you're like, oh gosh, no, I didn't know that.
Right.
Then it's like egg on your face.
Yep.
So I always tell people, like, if there's got to be somebody on the team who knows the entire lay of the land. And I think the PCP, a geriatrician, a case manager, those are the types of folks that I think are in a place to have that high level awareness.
That's right. What are some of the obstacles for actually having this type of team? Particularly like if you've got multiple health systems or, my specialist is 2 hours away.
Yeah. I mean, I think that challenges are obviously access, right? Access to these specialists, both from a proximity standpoint, where you live, what's available to you in your area, and then from a financial perspective, access, because not all of these types of disciplines are reimbursable. So a lot of the work that, all the people who are doing a lot of this behind the scenes work for patients, which is probably more important at the end of the day than sometimes what that clinical provider is doing. And they're not billable services. So these are large costs in terms of what it costs to fund these positions. But they're not necessarily ones that get reimbursed for, if they're spending hours and hours on a phone call or, doing paperwork for patients, doing in-home assessments. So there are different, some of the services can be billed out, and now Medicare has begun to realize that in order to be able to provide these types of services, which are very important in managing chronic conditions, and keeping people with high needs, more at home than in the hospital. So they've got new billing codes for things like advanced primary care management, chronic care management, transitional care management, advanced care planning codes, caregiver education codes. And some of those are also billed out based on how much time. So if it's, this to this many minutes, then you bill at this level. If it's, this many, 30 to 60 minutes, it's a little bit higher level. So there's some recognition of needing to be able to cover the cost of those services. And then I think we maybe touched on this a little bit, like in the other podcast, is that, being able to enter into an accountable care organization or a value-based care arrangement, where you may contract with a health plan and get like a per member per month.
Which is what Guide is.
Yeah, which is what Guide is.
Yeah.
So basically then that health plan says, okay, we acknowledge that to take really good care of this type of patient, you need these resources. And we value those resources at this amount per month. So now go take really great care of our patient, and they're essentially, funding what we can't bill for. So it's covering, hopefully the cost of some of that support staff, and then maybe even allowing us to expand. And, I'd love to have a pharmacist on our team at some point. I'd love to have behavioral health, nutrition, because we know that those are those tangible things that really help to keep people healthier. And
it's not always a med. Sometimes it's the med that's causing the problem.
That's right. So, I think having those more creative payment arrangements, or maybe creative is not the right word, but just an acknowledgement of the workload that is required to do actually what's right for the patient.
Right.
But, in a fee-for-service world, if the only person who gets paid is the physician, or the procedure gets paid, or the hospital gets paid, but like, how do you pay for your social workers and your nurses and your pharmacists and your case managers and
Therapy team.
therapy team, right?
Oh yeah. And we see that shifting, but it's a culture change for the providers.
Mm-hmm.
Again, I don't think families or patients know how siloed we are until they're in the system.
Yeah.
And then they get lost in the system.
Yeah.
It's like a corn maze, and they're just stuck somewhere.
Yeah.
And I think they get more frustrated because they feel like this makes sense. What we're talking about is really just common sense to medical care, but we've made it so difficult because of what you just described, the different payment codes and things like that.
And we've so much focused on how many patients you can see in a day, how many procedures you can perform in a day, that we haven't left time and space for what actually keeps people healthy, right? So that would be things like, time carved out for interdisciplinary team meetings, for caregiver education, there's a lot of different ways you can do it that, you can have high yield time that's not hours and hours in a day. So I think that if we have more value-based care, pay for your quality and your patient-oriented outcomes at the fore, instead of some of these metrics that just don't really make sense or add much value at the end of the day, then like we can actually do the things that are right for the patients and keeping them healthy and hopefully keeping them at home.
Absolutely. So kind of walk through. Y'all have weekly team meetings.
Mm-hmm.
Walk through what that looks like when oh gosh, we've got all kinds of things going on in our office right now. Sounds like Godzilla just jumped on our floors up there. Talk through what this looks like, and let's say it's physical therapy. Somebody else is bringing a situation to the table. What this looks like.
Yeah, I mean, I think it can be done a lot of different ways, depending on what setting you're in. But I think any good interdisciplinary care team meeting will have a structure to it.
Yeah.
It will have a facilitator. It will have some type of agenda. And you know, like a facilitator, somebody keeping it on track. And then, you know, people have different flows for their meetings. But if you're talking about going through and discussing, you know, individual patients on a service or in part of a clinic or something, then I think that the understanding would be that each patient is presented and every member of the care team for that patient has an opportunity to speak.
Right.
And so, and while that person is speaking, everyone else is listening.
Mm-hmm.
So there's not a back and forth. It's, okay, we're listening to hear and gather information. And then once everybody has weighed in, you know, you're back to that facilitator, or if it's the PCP or whoever, you know, okay, well, sounds like the thing that came out today that nobody else was aware of was that this person has now fallen 3 times. And the pharmacist mentioned that they started on a new blood pressure medicine a week ago. So it sounds like maybe there's a relationship there, and then that can maybe help the next steps. But I think that, you know, so that everybody gets a fair shot at speaking, the understanding needs to be that it's not like a popcorn thing, right?
No.
That like we have a process, and so we're going to go through and, you know, nurse, do you have anything to say? Pharmacist, do you have anything, like, and when people do have something to say, they say it, and then and their opinion is valued, and that culture is built intentionally with acknowledgments and appreciations and celebrations of wins. And
absolutely, it's not about, oh, I need to over talk this person and bring that thing. You know,
Right.
When you have a professional, supportive, interdisciplinary care team, it just runs smooth. I mean, you know, like when we're having one of our meetings and we're going over the different clients, the coolest part, and I'm sure you'll say this too, is when we're bringing something to the table and somebody says, oh, I've got a new great resource for that. Let me connect you with that. Oh, okay, they're falling. Well, let's, you know, do X, Y, and Z. Let's put this into the house. Or all these different things. It's when you can look at the whole team and realize and recognize that everybody's bringing experiences, information, resources to the table, that's the coolest thing.
Absolutely.
Versus when you're out there doing it by yourself.
Absolutely. That's collective wisdom.
Yep. Love that. Collective wisdom.
Yeah, collective wisdom.
Collectively, when you add up everybody's hours and days and things like that, it really, truly is collective.
And that's why I think geriatrics is so fun. Because we naturally have, I think our discipline, I think, has really embraced the interprofessional team component, and that it takes a village to take care of, you know, people who are aging and becoming frail, who have caregivers in different parts of the country, or, you know, there's family dynamics and all the things that you have to unpack to understand. But that's actually kind of what makes it neat, because it's not, no one person is the same.
That's right.
And being able to kind of like lean into that and take the wisdom of your colleagues, and, you know, it doesn't make it as hard. Actually, it makes it much easier.
Absolutely.
When you can call a friend or sit across the room from somebody who's got years of experience with that thing that you don't know what to do with.
That's right.
You know,
that's right. Because it's a lot more than just what diagnoses they have, what medications they have. I mean, a lot of times we're dealing with maybe something from a legal standpoint, from you know, a living standpoint, from just so many family dynamic standpoint, how we navigate this, you know, challenging family member, and how we communicate them and things like that. And one of the things when I asked Dr. Duxbury why he got into geriatrics, he's like, it wasn't because I really love geriatrics. It's because it landed into my lap when I realized that this was the only place I could actually be a physician and provide the care I want to provide, because it's that holistic bringing everybody together. And that's what I've always seen in all of the geriatricians that I've had the pleasure of working with, is you're seeing it from this whole person perspective.
somebody's got to be the one that's like flying the plane, seeing the 30,000.
That's right.
That's
right.
because it's oftentimes not the individual people that are, driving the whatever path. But they need, somebody's got to be looking at it from a big picture, and then helping to navigate what others are not seeing.
So what the takeaway here is, you can develop as a family member your own interdisciplinary care team model, if you will, by advocating for yourself, asking questions, and I don't want to say in challenging, but like encouraging or kind of motivating the providers that you have part of the team to be able to communicate and tap into the resources that they have.
That's right.
Maybe they have a particular home health company that they like to use because they like the way this therapy does X, Y, Z. And so ask those questions.
Yeah, I think that's right. I think being empowered, and I think portals are good ways of communicating. And sometimes it's the thing that like, it's not really urgent, but you really want to like be thoughtful and be able to articulate your, whatever it is that you're thinking. And so that can be kind of a gateway to actually open up conversations. And it's also, I can reference things that people have shared with me when I'm then communicating with other providers. And so I like using portal. I think it's a good way for folks to be able to preload questions that they may have for a visit, so they don't have to write them all down, and a provider can have a little bit more time to kind of plan, prepare. So, and again, I think even though people don't necessarily maybe not have the access at the ready for each of the interprofessional team members they may want, at least having an awareness that it may be an option to talk to a nutritionist. It may be an option to ask the pharmacist that they go to like review their medicines for them, and just say, do you see anything I should be talking to my doctor about? Because sometimes the pharmacist, if they're an engaged pharmacy, maybe they, I tend to think the local pharmacies who know their patients well are a little bit more engaged. But, to say, you might want to talk to your doctor. You've got two different medicines that are pretty similar. But on the flip side, a family member or patient can say, gosh, mom takes a lot of medicines. Like, do y'all think there's something I need to talk to the doctors about? Asking their home health therapist, like, is there a piece of equipment that you think we could use? So, and then, sending that to the physician or the APP or whoever, case manager to kind of help get some of those things. There's also a ton of resources available now through online, and I don't like people to just like believe everything they see and read. So I say, find your trusted healthcare professional and tell them, I'm trying to find a little bit more information about this. Can you navigate me to some trusted resources?
100%. Yes, absolutely. So there really are some incredible ones if they're trusted, and we know that it's a reputable source versus some of the other things that are out there. So I'm going to tease a little bit about our next podcast that we'll do together.
It sounds good.
And we've talked a lot about, you've mentioned the term frailty. Is that actually a diagnosis code?
Oh, yeah.
Okay.
For sure, frailty is. Yeah, I don't know what the numbers and letters are.
Yeah, I know we're going to switch
that one. You've got frailty, you've got frail elder, you've got frailty phenotype, you've got a lot of frailty options. But I think that maybe something that we could talk about in the future would be how to define aging. How to define age and the different ways to think about age from a perspective of what matters in terms of how does your age, in quotes, impact your longevity, and then what is frailty, and what does frailty actually mean? Because a lot of people, like, they hear the term frail, or we say somebody is frail, but they don't really know, kind of have an idea of what that means. But in healthcare, it actually is a very powerful adjective, and it actually carries a lot of weight in terms of morbidity and mortality.
Yeah.
So,
yeah.
But yeah, just I guess as a teaser, People can go online and look up, how do I calculate my functional age?
Okay.
Which is different than your calendar age.
Yes.
Yeah.
Yes.
And it actually is more important in knowing how well you're living and how long you may live.
And then to give a last little plug, what's also unique about the two of us is we both know each other's moms.
I know. And we both helped out.
We both helped each other's moms.
Yes. Yeah.
And we're seeing our moms. So both of us have lost our dads, but we're seeing our moms, and our moms are like fine wine. They're like getting better with age. And we may even have to have them as part of our, if we invited them, that'd be
hilarious. We need to.
No, Maria is going to talk a lot more than my mom. I'll tease out my mom. So,
she definitely would be uncensored.
Oh, Maria would totally be uncensored.
Yeah.
And then if we get my mom, Jan, talking about, she could talk about building an interdisciplinary care team. She really built one, right? So she figured out how to take the notes and send the portal messages and all those kinds of things. But both of them, when we talk about where their calendar age is very different from their functional age and just everything. So yeah, more to be
awesome.
More to come. So we can kind of start that one with frailty and what that means. And then we can end it on enlightening this.
Oh yeah, for sure.
What it looks to successfully age. Right?
Absolutely, yeah. Aging goals.
Aging goals.
Hashtag aging goals.
Hashtag aging goals. Yes.
Yeah.
And it may be a 4-part series.
That's right.
If we get the 4 of us on a podcast together.
You may actually have to have some bleeper. Like, how like when people, it would be, my mom would be very uncensored.
Oh yeah. Well, hey, it's all right. She's aged well, so she can.
11%. 100%.
Okay, so build your own interdisciplinary care team. What does that look like? It starts with being an advocate and seeking out who is going to be either your Nick Saban on your team, your quarterback, whatever that looks like. But I think the one thing to lead with, a main thing to lead with, is you don't do this by yourself.
No.
And you don't do it with just your spouse or just a friend or a family member or whatever. You've got to build a village.
That's right. You need a captain.
You
need a captain on your team. And, I think that if we think about the patient family unit as like one of the captains of the team, because really they're the main player, right? And then hopefully they have an equal partner captain in their primary caregiver or their case manager or someone who is, helping them drive that ship. Right. And then all of the other people on the team are those interprofessionals. And I think that's the way I would start, is like advocate for yourself. It's your life, your loved one's life, and you absolutely should be part of like driving the ship.
That's right.
Not be driven around.
Right. And ask
not be driven around.
Right. Not be driven around in a foreign language that you don't know.
Yes. Ask questions. Do not assume, and don't be afraid to push back a little bit and to say, is this really necessary? Is this the best way to do it? Be a partner. Tell your caregiver, tell your providers like that you want to be there. You want them to be a partner in your journey.
Are you sure mom that's older with dementia should have Ambien?
Correct.
Or Benadryl or Tylenol PM or
I really need your help in like getting us to, I know that we need to take the keys away. I absolutely know that needs to happen. I think that she would hear it better from you, or you could write a prescription that says do not, all the things.
Or going to the driving assessment or all of those different things. That's right. So we're leaving with everyone building their own interdisciplinary care team. I'm trying to say that fast 3 times. And then we're going to tease you with what is it? What is frailty? What does that mean to be frail? How is that impacting the healthcare system? And then what we can do to combat that. And then even maybe have some fun times with both of our moms and really live what it means to be aging uncensored.
100%.
Again, thank you. Always fun when the two of us are on together. We'll sit here and talk forever. We could talk even longer. Taylor's like, But thank you, Dr. Marianthe Grammas, and for everything that you do, and also just being a close friend of ours. So we're going to wrap up. I hope you liked it. So like, subscribe, share. We've been kind of on vacation, not literally, for the last few weeks. So we're going to be ramped up again as we get going. Our guide program starts July 1. We're super excited about that. So for more information, give us a buzz at Life Care Solutions. If you want to know more about UAB House Calls and what Dr. Grammas and her team are doing, all you got to do actually is look up UAB House Calls. It'll come up. She's got her own site, everything else, what that looks like, and maybe how you could get your loved one connected with them. And continue to stay active, stay an advocate, and like, share, subscribe. We're on Apple, Spotify, YouTube. Golly, it's been a minute since I've done all this. I'm looking at Taylor, our wonderful producer. So thank you, and hope everybody's having a good summer.